reproducibility here has not been good. Alternative techniques have been worse. The RT-PCR data says too much target, adverse outcome, meaning 5FU doesn't work well when the target it's addressed against is abundant in the tumor cells, prefers it to be low. IHC data, absolutely the opposite. Not enough TS or DPD in the cytoplasm of stained cells, no chance to respond to a 5FU regimen. I don't know how much Response Genetics is a company that offers these types of RT-PCR for these markers. I don't know how popular it is, but it's still, I find it somewhat conflicting. You know, since it's part of both the FOLFOX and the FOLFIRI regimens, it's likely to remain a standard of care for colorectal cancer. Nonetheless, whether it's given as the intravenous infusion or as the oral capecitabine or Xeloda. What about platinum? The data started in lung cancer, and it was with markers of the DNA repair, the excision repair, or so-called ERCC1 marker, and whether ERCC1 could predict resistance to platinum-based chemotherapy for colon cancer is only just being addressed. At last year's ASCO, the first study I saw, and it did have a very positive result. I haven't seen the full-length paper. It said that if a patient had ERCC1 overexpression at the message level by RT-PCR, that tumor was likely to be resistant to FOLFOX, to an oxaliplatin-based regimen. More studies are coming out at the meeting the next several days, and we'll see whether it holds up. I mean, curiously, not only has ERCC1, which originally was used to predict outcome in lung cancer on a platinum regimen, been extended to colon. I saw one study that showed an ovarian cancer where platinum is the cornerstone drug, that an ovarian cancer overexpressing ERCC1 was resistant to platinum. Now, we know 60% of ovarian cancer is resistant to platinum, probably, so maybe that's not the marker predicting that, but nonetheless, it still was interesting. But the one that shocked me was the first study in testicular cancer. Now, here we have testicular germ cell neoplasia, where we think that all testicular cancer is platinum sensitive. I mean, that's the Einhorn regimen. That's the regimen, that's the cornerstone for curing a disease that used to be fatal. We know we never cured 100% of embryonal carcinomas and choriocarcinomas of the testis with platinum-based chemo. There were always a few patients that unfortunately grew right through the drug, metastasized to the CNS, and succumbed. Well, the study showed that those patients all overexpressed ERCC1, that their repair capability was so high that as damaging the platinum was to the DNA of these tumor cells, they were getting them fixed up enough so they could reproduce and produce more progeny. So I'm pretty positive about an unvalidated, not prospectively randomized. All the ERCC1 data is retrospective, in which patients aren't being tested and then given or not given a platinum regimen. They're all patients who are on platinum regimens whose tumor DNA or RNA was tested by RT-PCR or protein by IHC after the fact. So how can we make treatment changes based on that yet? Nonetheless, I'm already doing IHC-based ERCC1 on all our new lung cancers, and now they're asking for colon. It's a clue. If you have a choice between two regimens with a patient with metastatic colorectal cancer, especially if it's RAS mutated, where you're not thinking of cetuximab, and you got to decide between FOLFOX and FOLFIRI, my feeling is, well, ask the pathologist to do another IHC for ERCC1. If it's positive, give them FOLFIRI. If it's negative, consider giving them FOLFOX. But try to give a little bit more, let's call it a favor on the patient's side to getting them on a regimen that's more likely to work than not, even though the test isn't validated. Now, is that good medical practice? Probably not, because it's not evidence-based. But it's just what I think will ultimately be vindicated and validated, but it's not yet, not yet. What about irinotecan toxicity? Of course, we want to avoid the serious diarrhea and the neutropenia associated with certain patients who have the UGT1A1 polymorphism associated with the metabolism of the active SN38 portion of irinotecan. And this test is now widely available. It's a genomic DNA genotyping polymorphism test. And a lot of investigators feel that if you think there's any risk that a patient is going to get a serious side effect, you should test them first before you put them on a irinotecan. And this one, there's not too much controversy on how to do it, and there's not too much controversy about its value. I mentioned earlier about HER2 testing in GI malignancies, and so I don't need to go into it again. I think we will be doing IHC for stomach cancer in the near future now that we see a survival benefit for a trastuzumab platinum combination. And now to lung cancer quickly. It's very similar in some ways to colorectal cancer, except for the most part, it's a small molecule EGFR inhibitor, not the antibody. Other than that, we have the same issues with an additional marker, possibly for gemcitabine response, which again is not validated. And finally, about the BEV. So EGFR staining. It's not standardized in lung cancer. Poor correlation with the copy number of the gene, interesting, and not a proven predictor of erlotinib response. So no need to do IHC. But what about FISH-based? You can clearly do EGFR by FISH. The group at Colorado, Paul Bunn, Fred's group, they are extremely interested in FISH-based testing for erlotinib response, not gene sequencing. They represent the, we think, copy number. Fred Hirsch and Paul Bunn is more important than having a so-called erlotinib-sensitive mutation in EGFR, as contrasting with the Boston hospitals, the MGH and the Brigham, that described in two separate articles the different gene mutations associated with EGFR response. Some investigators think it's best to have both. If you've got amplification data and mutation data, that gives you more information. But generally, they actually correlate pretty well. Most of the amplified EGFR lung cancers that have extra copy numbers usually have a mutation that's sensitive to the tyrosine kinase inhibitor, to the erlotinib, but not all. And it's a raging controversy and a fight. It's fun to watch it in the literature and even in public, where the amplification group says that's the test and the mutation group says no, ours is the test, and each thinks the other is wrong. I don't know which is right. Between you and me, I'm not that impressed that the drug is that wonderful in whether the patient's sensitive or not. Certainly it gets dramatic responses in sensitive patients, but how durable are they? Again, unfortunately for this disease, I think everyone in the room will agree only the surgeon can cure it. And if the surgeon doesn't cure it, the chemotherapy can only palliate. We want to palliate as best as we can. We want to palliate for as long as we can. But this raging controversy about erlotinib, given the survival benefit impact, I find somewhat of interest. But that's because I'm in breast cancer and trastuzumab oriented, so I have a high bar standard. Mutation testing for EGFR, again, it's not a standardized method. Different techniques can be used, which have different sensitivity for picking up the mutations, but mostly most of the laboratories that do it get similar results. So I wouldn't call it a serious technique issue, but it's a favored, probably more than any other test, as the best predictor of erlotinib sensitivity, with FISH not being as favored, unless you're from Colorado. What about RAS mutation testing in lung cancer? It's been around a long time. It generally occurs in about 1/4 of non-small cell. It's somewhat lower in non-smoker adenocarcinoma. It's very rare in squamous carcinoma to get a RAS mutation. It's really an adenocarcinoma feature. 97% in 12 and 13, and the remainder probably in codon 61. It's not been an independent prognostic factor for non-small cell lung cancer, curiously. And in the Tribute 3 trial, erlotinib was found to be ineffective in KRAS mutated non-small cell lung cancer. And when it was added to standard platinum Taxol chemotherapy, those patients did worse. So that's made some feel that RAS testing for lung is also indicated, and that erlotinib should definitely be avoided in a RAS mutated adenocarcinoma. Same method for doing RAS in lung and in colon.